I'd like to give you a brief introduction to the external features of the heart in preparation for your sheep dissection class coming up. This video is for the anatomy and physiology class at Mercyhurst Prep. So as you can see, I don't have a sheep heart in the office, but I do have a model. So let me briefly show you a few things. This is a human heart model, but the sheep heart is almost exactly the same as a human heart, with probably just one exception. I can only find one exception, one difference between a sheep heart and a human heart, and it has to do with the branching of the aortic arch vessels. The aortic arch is coming up here and it's going to go around behind the heart, and this first branch is called the brachiocephalic artery, which bifurcates into a right subclavian artery and a right common carotid artery. The next branch in a human comes off separately. It's the left common carotid artery. In a sheep, though, this comes off a common trunk of the brachiocephalic, so I've read. I doubt if the aortic arch vessels will be still attached to your sheep hearts. Let's hope so. However, I've seen plenty of common trunks in echocardiograms that I've performed showing that it's not an uncommon variant for the left common carotid to come off a common brachiocephalic trunk in humans as well. But the point is, the sheep heart is exactly like a human heart. And if you were to now if you're facing somebody, let's get oriented. This is going to be the left side, the person's left and the person's right. The head's up here, feet are down here. So we have left, right. It's positioned in the left part of the chest. Everything going out in this direction is going to go lateral, left lateral. Anything going in this direction is going medial. So this would be inferior, this would be superior, this would be anterior, right? If you turn it around, you're posterior, okay? This would be superficial. Anything going deep to it is deep, so we have superficial and deep. You could also call this cephalid and caudal. So it's important to get used to these anatomic terms instead of saying up, down, over, above, because you don't know how the how the individual is oriented. So the right ventricle is obviously going to be on this side, correct? Because this is the right side of the heart. What you're going to now let me just mention one more thing. The heart is going to be pointing. It's kind of like a triangular little. It's almost triangular or elliptical. The apex of the heart is going to point down toward the left. If I were to orient this right down the middle between the left ventricle, which is here, and the right ventricle here, it would look like this. But in fact, the heart is oriented more like this. So as you can see, the left ventricle here is much more posterior than it is leftward, but it's posterior and leftward. And the right ventricle, which is here, this whole area under here is going to be right ventricle, is rotated out around, and it's mostly anterior. So anterior and to the right. Now the other, it's also not straight up down. Here, this would be straight up down. It's really not like that. The heart is tilted backwards. So if you actually turned around, if you came around the heart, you would see that the posterior part of the heart, which is comprised of atria, these are the atria are under here. They're not only superior to the ventricles, they're a little bit posterior. This is a little bit exaggerated, but you'll see arteries that come back from the lungs to the left atrium over here are not only pumping, or not only, well, they do pump a little bit, pump downward into the ventricle, they actually pump forward. That's a little bit exaggerated, okay? So the atrial blood actually pumps forward and inferiorly, or I should say anterior, shouldn't I? So let me point out some of the features externally. You're going to find a groove called the interventricular sulcus on your sheet part that runs right down along, it's like a marker identifying the interventricular septum. The left anterior descending coronary artery runs along in this groove. To the right of it is the right ventricle, to the left of it and posterior is the left ventricle. The two great vessels here, which come off the superior portion of the heart, are the pulmonary artery here. Anterior, you see the pulmonary artery is anterior to the aorta. The valves are, let's see if we can open this up. These are the valves. These are the semilunar valves. You'll see the blue means deoxygenated blood, and that's carrying blood from the pulmonary artery, you see? So, pulmonary artery is anterior to the aortic valve, or the ascending aorta. You see that? So when you listen with a stethoscope, you're putting your stethoscope at the top of the chest. A lot of people call that the base. If you put your stethoscope here, you can hear the closure sound of the pulmonary valve right here. It's much softer, it's less intense than the aortic closure because it's under much lower pressure, but you hear it well because it's right under your stethoscope. Behind it, or posterior I should say, is the aortic valve. You can hear that easily. So you can actually, with a stethoscope here, this valve close and then this valve close separately. That's the second heart sound. That's the dub of the lub dub. And you can actually hear two components, and it will sound, let's see, it's kind of like this. Here, let me tap it for you. Did you hear? You'll hear one sound. That's the lub dub, okay? But in fact, as you're breathing, you can distinguish two sounds. Did you hear that? That's what it sounds like to listen to the dub part of the lub dub. Now the only reason I can hear that the two components is that the soft one is in anterior, right under your stethoscope. There is a condition called transposition of the great arteries. These are called the great arteries, where in fact this aorta is coming off the wrong ventricle. It's over here in place of the pulmonary artery, and the pulmonary artery is behind it. And in that case, you can't hear splitting of the second heart sound. The dub part of lub dub is just a single sound, and that's one of the several reasons which can cause a single second heart sound. But we're getting a little bit beyond senior anatomy and physiology, aren't we? But every little bit helps, doesn't it? Now let's follow the path of blood through the heart, and let's start on the. We'll start here in the right ventricle. They're running down the middle. You can see the interventricular septum here and here. So the right ventricle is on the left side of the screen, you see. This valve here represents the tricuspid valve. So blood which is beginning in the cavity of the right, or the body of the right ventricle here, is going to be pumped into this artery here. So if I open this up again, it's pumping in this way and then out through this semilunar valve called the pulmonary valve. You see there are three half-moon shaped cusps similar to that valve which was posterior to it, the aortic valve. If I lift up the leaflets of the mitral valve on that side, you can see that too. Not very well. So the anterior part of the heart is pumping blood into the pulmonary artery. This artery bifurcates. See, I'm going to turn it around. It bifurcates into these two branches. The right pulmonary artery and the left pulmonary artery. See, now I'm looking from behind. You see that? The aorta comes up and over. Now, the lungs are not attached. They won't be attached to your sheet part. Blood in the pulmonary artery is deoxygenated. It goes to each lung, and then it returns from each lung back to, I'm going to turn the heart around again so you can see. It's going to come back around and enter the left atrium through these four pulmonary veins. They're color-coded red, you see? Two from the right on the right side of the screen, two from the left on the left side of the screen, entering the left atrium. So now blood enters the left atrium with oxygen, so it's coded red. Left atrium is a thin-walled receiving chamber. Let's open it up. There are the entrance of the veins into the left atrium here and here. It will then go. This represents the orifice of the mitral valve here. Or let's look upward here. See? So here's left ventricle on the right side of your screen. This is mitral valve. Your book calls it bicuspid. Nobody calls it that. I don't know why they persist in using that terminology. It's the mitral valve because it's shaped like a bishop's mitre, and so it was called the mitral valve. So the oxygenated blood moves, remember, anterior and inferior through the valve and into the chamber of the left ventricle. The walls of the left ventricle are very much more finely trabeculated, whereas the right ventricular, the interior of the right ventricle is much more coarsely trabeculated. So this has a much smoother wall, a left ventricle, than a right ventricle. You'll also notice that it's the wall itself, the muscular wall, is thicker on the left side. It's actually a little bit more dramatic than this, but there's more muscle, there's more pumping muscle on the left than the right, and the reason is it needs to generate a higher pressure in order to overcome the higher resistance of the blood vessels in the branches of the aorta. That's the actual reason. Your book had a slightly wrong explanation of why it's the left ventricle is thicker, if I'm remembering correctly. You've got to think in terms not of pressure that it's pumping against, but resistance that it's pumping against. When you are born, your right ventricle is equally as thick as your left ventricle, and it's only after a few weeks that it becomes thin. And the reason is that before you're born, the resistance of blood pumping into the pulmonary artery is high. It's very high because the lungs are not inflated. So consequently, the right ventricular muscle is also thick. And the same thing is going to happen with anybody who is born with a very deformed or dysplastic or thickened or narrowed valve right here. If this ventricle here, the right ventricle, had to pump against a tiny narrowing, its muscle would become thick. But in the normal scheme of things, the right ventricle the right ventricular muscle is thin because the resistance in the pulmonary blood vessels is low, and it drops very quickly in the first few weeks of life. So resistance in the lung vessels is low, resistance in the systemic blood vessels, branches of the aorta, is high, and that's the reason. So now blood in the left ventricle is ejected anterior to these leaflets of the mitral valve. The mitral valve has an anterior leaflet and a posterior leaflet. This model doesn't show it very well, but you can see it goes up over the valve, over the anterior surface of the mitral valve, and into this other, you see, semilunar valve that's posterior. You see? Anterior, posterior, anterior, posterior. It's ejected out the aortic valve. The first branch, you can see, you see this branch here of this is the left coronary artery. It's going to branch into the anterior descending, which is this one, and a circumflex, the left circumflex coronary artery, which runs back in the groove between the atria and the ventricles, and going posterior, behind the heart. Oxygenated blood then comes up the aorta, goes off to these three arching vessels, and down and around, and supplies the rest of the body. After the oxygenated blood goes through the systemic capillary beds to deliver oxygen, it goes into the vein, veins, which then all collect back into two great veins. I'm going to turn the heart. I'm going to come around on the side a little bit to show you the relationship between the superior and inferior vena cava. Here, coming from the head and neck vessels, is the superior vena cava, draining practically straight down into the right atrium. And here, see, coming from below, venous blood from the lower body it comes into the inferior vena cava, and they all drain into the right atrium here, you see? So if I open it up, we have the right atrium, and over here was the left atrium, and a wall down the middle called the atrial septum, which is supposed to be completely intact, but is never intact when you are during fetal life and in the first probably few weeks of life. There is a communication, which is not shown here, across this atrial septum, so that blood from the right atrium can cross it into the left atrium before the lungs have developed. It gives it a place to go. The atria also have distinctive appendages. Your book calls them auricles. Nobody uses that terminology anymore except maybe some anatomists, but we don't. We never call them auricles. They're atrial appendages. On the left side of attached to the left atrium, you're going to find this on the sheep heart as well. This sort of like outpouching. It's kind of like it's kind of an oblong, elongated outpouching called the atrial appendage. This always identifies the left atrium. If you're examining a specimen with very strange defects and you're not sure which is the right atrium and left atrium, because sometimes they can be reversed, if you find a left atrial appendage, it's always the left atrium. The right atrial appendage they represent somewhat on this model here. You'll be able to see these on the sheep heart. Now there's perhaps one other feature demonstrated on this model which I should explain. You might have been wondering, if you've been paying careful attention to this, what looks like a blood vessel connecting the underside of the aortic arch. I said under again, didn't I? The inferior surface of the aortic arch and the region of the bifurcation, or near the bifurcation of the pulmonary arteries. This will probably have been cut away. I'm almost certain it will have been cut away from your sheep heart. But this, in adult life, is a ligament. It's called a ligamentum arteriosum. And in fetal life, this was a large vascular pathway. It's made up of special tissue. It's an actual, not quite an artery, but kind of like an artery, which provided a pathway of blood to go from the pulmonary artery out to directly out to the aorta. This was much bigger here. It was probably the same size as one of these branch vessels here. You see this in the fetus, and you can see this in every single newborn on the first or second day of life. It's still open. So in the fetus, the blood can go from pulmonary artery. Remember, the lungs are deflated, so there's really hardly any place for it to go. Hardly any blood goes to the lungs in fetal life, maybe 10% of the output. So it has to go somewhere else. It goes through this large artery and back down the aorta. That's called the ductus arteriosus. And in adult life, or in an adult heart, you will see it represented by a ligament. The ductus just kind of pinches off. It's very specialized tissues. It just turns into a ligament. So that concludes our very brief and very unprofessional tour through the external and some internal features of the heart. I apologize for the unprofessional character, but it's all I had. You'll also find that when you open up the heart, it doesn't look quite like this. You'll be surprised at what the HAV valves, in other words, the mitral and the tricuspid valves, actually look like. You may want to experiment. I don't know, you're going to be in different groups. You may want to experiment with different ways of dissecting the heart. I don't think everybody has to do it exactly the same, as long as you compare your dissections with one another. For instance, normally we don't dissect the heart straight down through what would be called a cross section. This would be called if we cut straight down through the middle this way, in this plane, that would be called a horizontal section or a cross section. Perhaps some of you want to do it that way. The traditional way of teaching this, I believe, is to turn the heart up like this and cut upward through the apex and up here in more of a, I guess you would call it a sagittal section. So let's see, this would be a cross section. Cutting down a medial plane would be a sagittal section. So anything along here, any slice along here would be sagittal. And anything cutting across this plane would be a coronal. I think I've got that right. So you might want to experiment, and we'll decide how we're going to do it. I haven't quite decided how we're going to, if I get a heart tube, I'm not sure how I'm going to do it. Typically I just start incising in the atria and cut all the way down through here so that I can open up the right ventricle, and then I open up the left ventricle. But we can decide when we get there how we're going to dissect this.